12th Tanzania Health Summit. I'll be the moderator for this session, and it will take us up to 12:30 sharp, and I hope we'll make sure that we are on time to allow other partners to. So our session today is going to focus on a very important topic. We all know that on recent years, we have witnessed and experienced very serious outbreaks, pandemics, and events of public health emergency. The pandemics, the outbreaks, COVID-19 of the unprecedented, of the large scale that we've never seen before. All these prompted to having a lot of critiques on how our health systems are ready to respond and preparedness for these such events of public health emergencies. We had seen the gaps which were exposed at the healthcare systems in all the aspects, all the components of healthcare systems, the inadequacy of human resource for health, the inefficiency of supplies of emergency and commodities, etc., the financing of healthcare system, which was extremely a huge gap, the governance and leadership, which was not very focused on prioritization and accountability. So all these kind of the gaps that were exposed prompted for all the partners and stakeholders in the health sector to really come up and think of what can we do, especially in the global south, in Africa, and Tanzania was not spared. And this was a time when Amref Health Africa, we also had an opportunity, great opportunity and honor to partner with Africa CDC and Ministry of Health of Tanzania mainland, Zanzibar, and also the PRH. With the support and generous funding from MasterCard Foundation, we were able to pioneer and integrated community center solutions to strengthen health systems and preparedness for emergency. And this is when we came up with an initiative which was known as Saving Lives and Livelihood, SLL. I think most of you have seen it, as it was implemented in many parts of the country. And the main focus of SLL was to build a very robust and resilient system for immunization services across the country. So this forum today, as you've seen, it's about building pandemic resilient health systems, integrated life cause immunization through the Tanzanians SLL, the Saving Lives and Livelihood experience. So we will share evidence and strategies from both the United Republic of Tanzania on multi-disease response. We will also showcase the decentralization of health systems and how this worked very well in terms of preparedness and response. And the most important thing is scalability and sustainability in our continent. So before we dive into this very enticing conversation this morning, I'm humbled to invite the country director of Amref Health Africa in Tanzania, Dr. Florence Tem, to give us a brief opening remarks, and then we'll proceed. Welcome, Dr. Florence.
Thank you, Dr. Isa. Good morning, everyone. My job is very simple. It's just to give blessings. And for me, it's really an honor. And on behalf of Amref Health Africa in Tanzania, I must say that I'm thrilled to welcome you all to this very defining moment when the entire world is looking into resilience amidst various pandemics. But as you see, our topic of the discussions today is around building pandemic resilient health systems, integrating life course immunization through Tanzania's experience in SLL, Saving Lives and Livelihoods project. So there will be some experiences being shared, but also outside our project, we can also hear from the audience. So we know that amidst global health shocks, basically it's when COVID-19 started, we also saw other outbreaks, but it was not the first time to experience such outbreaks before even COVID-19. But out of that, we learned that there was urgency to build stronger and more adaptive and inclusive health systems that need to be resilient even during the time of outbreaks. So the forum here is basically to stimulate and catalyze dialogues and propositions that are meant to translate evidence into actions and to turn challenges into opportunities. And also to safeguard everyone's life from the life course, from the infancy throughout the life course. And we got our lessons during this time. And I said it's an opportunity. We learned a number of things, and we'll be having an opportunity to share those lessons that we got. But we'll be together with you, we'll be reflecting to the entire journey, what were the successes and challenges and lessons. And for us as Amref Health Africa, we work in partnerships. And in response, we've been among the key partners. We've been responding to such unprecedented incidences. And we do that through technical assistance, with working close with the Ministry of Health, but also our PRAG offices. And we've been responding to various outbreaks, including the Marburg that happened in the country, but also getting ready, the readiness, preparedness for the other outbreaks like the threats of Ebola and the like. Also promoting community engagement, demand creation, and community-based event-based surveillances, also be part of the training and technical support. However, Africa, if so to speak, not just Tanzania, we remain prone to more outbreaks, zoonotic diseases, but also other acute public health emergencies. So today here, we'll be hearing from a very renowned group of people, yourselves who are sitting here, but from the government officials as well, the panelists, Africa CDC is here with us, we have development partners with us here, health professionals, and other community voices who might be in the room. So together we illuminate our path. So we basically call this, it's not just, it's more than a dialogue. We have to solicit some commitments, some actions, calling for actions, but our aim is to make sure no child is left unprotected, even no mother is overlooked, but healthcare workers also are not left alone to face health threats without being protected. And all to do this is to ensure that we support the immunization processes, and many to do with the infrastructure, but human resource capacity, or logistics issues, and all is aiming at systemic protection. So to seize this moment, to connect ideas with actions, to catalyze innovations with evidence, and we shall hear some evidence here. And we know that we have key questions. That means in terms of resilience, sustainability, amidst climate change, antimicrobial resistance. These are things that we need to address. The population is growing across Africa, even ourselves, at the rate of more than 2.5 up to 3%. That tells that demand is still there, and more outbreaks are anticipated. Our immunization programs remain to be donor dependent, and yet we're talking about sustainability, but we're glad that our governments in different stages are allocating resources. So we need to sustain our gains and ensure that we address also myths and misconceptions and promote health literacy around immunization and promote resource integration. We are told by Gavi, from the fact sheet of Gavi, saying that $1 investment in immunization from 2021 up to 2030, you save $31. That would have been lost out of illnesses and healthcare costs, etc., and the return of $54. So this is really a useful investment when it comes to investing in immunization. So I welcome you all to become very vibrant, be participant, share lessons. We all know how we responded to how things happened when outbreaks came. Our systems, people were missing some immunization because of the threat, but then we are back and we need to support each other. So it's an open discussion, and I take it back to the moderator. I hope your team is here ready to join at the podium. Thank you. Karibu, Doctor.
Thank you so much, Dr. Florence. I think you have highlighted very important issues that we are looking forward to be discussed this morning. And now I will have an honor to invite our distinguished speakers. I will call them one by one to come and take a seat once I call you. I will start with Dr. Fatma Kabole, Deputy Director for Preventive Service and Health Education in Zanzibar, Ministry of Health. She specializes in project design, and she was really instrumental in designing these projects, the core design part of it, the guru, and mentoring district medical officers, overseeing mental health initiatives, and strengthening health institutions across Zanzibar. Karibu sana. A round of clap for Dr. Another very esteemed, distinguished gentleman, Dr. Florent Tinuga, Immunization Service Coordinator at Pure Large. Is a public health specialist and medical doctor with over 15 years of experience in health systems, strengthening and primary health care transformation in Tanzania, currently coordinating immunization services at Pure Large. He has held key leadership roles advancing universal health coverage, routine immunization, and COVID-19 vaccination, and is recognized for strategic leadership in building resilient, equitable health systems. You cannot separate Tinuga from immunization. When you say immunization, you think of. Thank you so much for joining us. Then we have another very esteemed gentleman, all the way from Africa CDC, Addis Ababa, but he is stationed here in Tanzania. He's a senior epidemiologist, over 15 years experience in disease surveillance and public health systems across Africa, currently serving as Africa CDC's senior country representative in Tanzania. He leads national initiatives in epidemiology, surveillance, and outbreak response with expertise in health information systems, One Health, digital health, emergency preparedness, everything. Welcome, Dr. Robinson Naji. And another, I usually tease him and said, he will understand, Mtani. Dr. Juma Mfanga, the regional medical officer of Njombe region, very sharp guy. A medical doctor, public health specialist with over 15 years of experience in health system strengthening. Njombe region is recognized for its cholera-free status and sanitation achievements. Excellent in resilient system for immunization and response for COVID-19. They have done tremendously well under his leadership. And he is known for strategic leadership, innovation. He is dedicated to building resilient health systems and expanding equitable access to life-saving interventions in Tanzania. And then I would like to now invite our very own, the project manager of SLL at Amref Health Africa in Tanzania, Dr. Sarah Kweyamba. She has over 8 years of experience in public health disease control. This is the first project she'll manage. The first time as a manager, and she has done very outstanding work. And she has been contributing a lot on national vaccination coverage. So thank you so much, and welcome. And now I'm going to my seat. policy to practice. So Zanzibar, Dr. Kabole, I'm starting with you. Are you ready? Zanzibar has the Zanzibar Immunization Strategy, and which was also adapted from the Immunization Agenda 2030. And you have been the champion in ensuring that it aligns with the local priorities. And with that, with the leadership, it's something that happened in Zanzibar that really made Zanzibar able to develop this strategy and implement at the local level, being accepted, being scaled at a speed that we did not see anywhere else. Can you tell us what was the enabler and what was the transformational enabler that helped you to do this?
Asante sana daktari. So I must say some of us during the COVID time, some of us were hard hit. As you know, our economy depends on tourism, and those were really hard times. So this project actually came amidst COVID times when we were about, at the almost beginning of 2022. And it has really helped us learn a number of lessons, including what can we do to make sure our children remain safe, as well as building our health systems. So this project, as you had mentioned it, SLL, it's funded through the MasterCard and with the support, technical support from Africa CDC and Amref as our esteemed partners. So some of the adaptations which, and I must say that we had achieved great milestones in the course of implementation of this project. So we did few unique things like doing micro plans which are really geared towards our unique geographical realities. We also had intensive community engagement strategies. We had, and one of my best interventions was actually integrated service delivery, whereby, especially during the outreach, we did integrated interventions with programs like the NCD. So it was not just immunization, but also other things, nutrition, as well as other things. And we had, what did we achieve out of that? We had seen tremendous increase in the number of adolescent girls who were immunized, even above 100. There were a number of healthcare workers who were trained, as well as our community health workers. And we had seen improvement on data use for decision making. Some of the enablers were, we have the strongest political will, I can say. During this term, awamu ya 8, we have not seen such big improvements in terms of infrastructure development, as well as the health sector was one of the president's agenda and priorities. So the political will was really at its strongest. Partnership with people like yourselves, Amref, and other partners like Japaigo and so on, with technical support from Africa CDC. And I must say the IVD program is one of the unique programs whereby they work with their counterparts from mainland. Hand in hand, they are like twins. And I take this opportunity to thank Dr. Tinuga and his team. Kwa kweli wanatushika mkono sana. Tunawashukuru kwa hilo. the capacity for, we know we have constraints in terms of the health workforce, but increasing their capacity has also helped. And as I said before, data-driven policies. We still have a few gaps, I must say, in terms of infrastructure. We are islands, we are not just Unguja and Pemba. And in this project, the good thing in 3 of the districts have the smaller islands where we have populations there, and some of the islands don't even have health facilities. So we had to do specific geared interventions to make sure we reach those islands because of the infrastructure challenges in terms of the cold chain. We can't store vaccines in those islands because of power outages and so on. As I said, we still have HR shortages, equity challenges, as I said, in terms of the islands and so on. But the biggest concern that we have is we are highly dependent on donor funding. And I think now it's time, we've seen even during this THS, that we are looking at domestic funding and how we can manage our programs without it. I think I've said enough. Thank you. Asante.
Yes, thank you so much. You have said it very well. And this also now connects directly to the second speaker. Now we are shifting to the mainland, geographically very large. But this means that it goes hand in hand with the gaps and the challenges. However, the structure in the mainland, we have the Ministry of Health who develops the strategies and policies and guidelines. One of the strategies that was developed during this time was the National Immunization Strategy, which was adopted from the Immunization Agenda 2030 Guide. And PRLAG now is another ministry which ensures these national strategies and guidelines are translated into action at the local government authorities level, the regional, etc. At the PRLAG, we have Dr. Tinuga there, who is the instrument, who is the driving force. And Tinuga, there is something which happened during this time. That's where people start speaking about decentralization and strengthening systems, connection between policy level and the actual. So how have PRLAG decentralized structures turned policy into practice, and what success or lessons helped expanded the engagement and the immunization services?
Yes. Yes, thank you. Thank you so much for the moderation, the topic. As I have been introduced, my name is Florian Tinuga. I work with President's Office, Regional Administration and Local Government, supervising immunization services. So with regard to the question, how does the PRLAG translate guidelines, policies into practice? That's the brief questions. You see, the health systems in Tanzania was decentralized way back, meaning moving power of decisions, power of planning, and all this around from the central level to lower levels. Now, the lower levels we have the regional levels and the local authority levels. So basically the decentralization was accompanied by devolutions. Moving power to lower level without empowering the lower level, it means nothing. So these two went in hand by empowering. So what was decentralized is the capacity of owning, planning, reporting, implementing, and what was the devolution was to ensure now those levels, they bring this in practice. So this is where we answer the question, how does the PLH turn the policy into practice? So it turns the policy into practice by moving power from central level, by then capacitating the lower structures to make the use of what is required. And the use of that is required, they are made through the structures which were made. The regional level, we have regional management teams, regional health management teams, which is governed by the regional medical officers, and then the local government by the district medical officers, or through the council health management teams. So the role of the PLH now remains on supervising, overseeing, scrutinizing what really have been transformed from the policy. So and how do we do this? Is simple. We do take their plans to see, are they really planning for immunization? Are they putting money? Is the money enough? Then we look at their data from lower level. We look, are the data speaking the translated policy or not? Are we vaccinating the HPV to 9 years girl or not? That is our job. Because the policy tells us to vaccinate the 9-year-old girl for HPV, to vaccinate the pentavalent for the newborn. So does that being practiced at the lower level after decentralization? So this is our job. The other job we do at the national level, PLH, is to ensure the resources coming from the, for the mother ministry, are they really directed and reaching the targeted facilities? That is our job. So we distribute resources. Yeah. So that's the kind of what we usually do. We don't own things. What are the major successes we have seen through this practice? The first thing is the ownership. The ownership. And once the ownership is done, we do see more success, like the rational use of resources. If ever each money is directed to the regions, to the councils, and then the councils and regions, they ensure that money targets to the directed facilities. So that's about the ownership, but also the accountability. If I give you a resource and I want you to achieve a certain target, that is your accountability, because in the end, I also ask you whether you have done so or not. So we see the accountability has come up. And when the ownership and the accountability is up in terms of immunization, what we see is the increased immunization coverage. The increased immunization, and we have seen this throughout. Before the pandemic, our country was throughout above the upper limit of 90% set by WHO immunization performance through the pentavalent indicators. But during during COVID, that was disrupted a bit, and we got challenges of under-vaccinated dropouts, which were increased. But it's because we had already a structure which is resilient to the response, we were able now to set up the catch-up plan. That is another thing which we saw as a success. So immediately we could respond and mitigate the outbreaks which were starting to emerge during post-pandemic. So the catch-up was one of the thing which, the strategy which really demonstrated that immunization performances in Tanzania is very strong and resilient, as the question is. So all this is because we had decentralized the power, the ownership, the capacity, the accountability, and everything. But also, we see another achievement we are seeing is capacities. Because in immunization system, you never achieve if you have not capable staffs, if we have not capable facilities. So in our part, as pure large level, we see capacities among the lower levels is very, very high. It's very, very high because they are doing themselves. One of the mechanisms of building high capacity is to let you do, and not me to tell you what to do on behalf of you. So this is another what we see as the high achievements. Though we still have some challenges. Now, where does these challenges come from? It comes from what you really mentioned, that the mainland is big. It has geographical disparities. It has a lot of hard-to-reach areas. We still see, as pure large level, we oversee, but we need the focused supportive supervision to come from the lower structures, but resources are still limited. So we still have a number of health facilities which are not reached during supervision as per the guide in a month, in a quarter. This is because the resources are still scarce. Geographical areas, we know in order to access the facility for supervision, you need to move. And moving for supervision is not by walking. You just have to use the vehicle. So they will speak the lower levels, they will speak the challenges of this around. No vehicles. If ever there are vehicles, no fuels. If ever there are vehicles, fuels, staffs are few. Yeah, you see all these, they are connected. And this is because of the geographic. So what does this translate? And then it translates on when you speak in the immunization context, all this leads into many children being unvaccinated. Despite the efforts we are having, despite having above coverage, but we still have children who are not reached by routine immunization antigens. Because we have, as I mentioned, but in addition to that, we do have communities which is still in hard-to-reach areas. We still have communities which are moving. The region like Arusha, you have more communities moving. Today they're here, they get the first dose, but the second dose you don't find them. So those are some of the challenges we are seeing. So what are we thinking at the pure large level as the solution for those challenges? The first one is, you see, we do have what we call the cascade supportive supervision. This is what we are thinking. And if I speak here, if there is anyone who can take this, that will be the output of the meeting. What does the cascade supportive supervision does? It do reduce the burden of the council health management teams moving far to reach out the facility for supervising. And what they do train. We think if we can train district supervisors at the lower level, at the ward level, at the village level, that may help. Because that will not need far moving a car from the district central office to 200 kilometers. Right. So that is one thing we think that can strengthen the supervision. But also, it can also strengthen the quality. The quality of immunization. Quality of immunization depends much on regular looking at how the vaccines are kept, how the vaccines are being given, yeah, what are the capacity of the staffs, and things of all kind. But the other thing is about access, vaccination access. You see, the government of Tanzania, as she said in Zanzibar, we saw the government made a transformation of health infrastructure systems. We have a lot of health facilities being constructed, but these health facilities, when you speak in terms of immunization services, are not functioning. And once these facilities are functioning, we will increase the access, and therefore we will reduce the zero dose. So you see, in times, the government may be running, but us may be lagging. And this is exactly what is happening. I'm speaking this because we see this at the president's level, because it's us who is transforming the policy into practice. So the policy of building more facilities, it is being challenged by its use due to some number of factors. So for now, let me pause here, and I'll be waiting for more from the audience. Thank you.
Yes, indeed. Thank you so much. Very good insight, as I told you, from the guru of immunization. Okay, now we would like now to broaden our lens into the continental. Africa CDC, if you don't know, is the health arm of the Africa Union. With how many member states? I think more than 50 or 50 something. So Africa CDC role, as you all know, is to really support member states, including Tanzania, to strengthen health systems and make sure they are resilient. And now I hear they are focusing very much on preparedness for emergencies and responses, etc. So Africa CDC has been very, very instrumental in development of the SLL project initiative. And we have Dr. Robinson Nanji here. You have been very instrumental, actually. You have a very broad knowledge across the region in terms of preparedness and amplifying resilience. And this includes supporting Tanzania in developing the after-action review framework. And all that's been done in different countries. So how has this AAR, which is the after-action review framework, how has it shaped the Tanzania preparedness, and how can this partnership have impact? How do you see the impact of this? Karibu.
Hello. Hello, can you hear me? Thank you very much. As introduced before, my name is Dr. Robinson Naji, the Senior Country Rep for African CDC. Moderator, thanks for the very good introduction for Africa CDC. Sorry, if I may, and if I can't be able to do justice to this question, I think I have two parts. The first part is about how AAR has shaped Tanzania preparedness, and the second one is about partnership with an impact. So actually, AAR is, let's start from the beginning, just brief. It's a part of the framework of international health regulation, which includes a regulation that comes together to be able to design methods and frameworks to be able to make countries to be prepared to respond to emergency. Part of those frameworks include what they call SPARs, State Party Action Reviews, includes what they call Joint External Evaluation, includes what they call CMEX exercise. All these things are frameworks done so that people can get prepared and be able to respond immediately. When we talk about CMEX, we're saying, okay, can we simulate like a disease has happened when it has not happened, so that we know how we can respond when it comes. So just the same way, like after action review is primarily done to look at what went well, where did you do well, where did you not do well, how can we improve? So basically, as African CDC, we are in line with the IHR framework on AR, and Tanzania being a member state are really in line with the framework of IHR and African CDC framework. most of the times, Tanzania has been top-notch in almost all the activities. Joint external evaluation has been done regularly. State party action reviews have been conducted regularly. CMEX has been done in all different diseases. And AAR is being conducted in every activity. So I want to give a practical example. Early this year, there was an outbreak of Marburg. And this was the shortest outbreak ever, because the outbreak was stopped 2 days after response. It's not by magic. It's by the lesson learned from the 2003 outbreak. Because at the end of the 2003 outbreak, there was after-action review that involved all the partners. And I looked at what is our strength? Where did we do well? Where did we not do well? How can we work on our gaps? And because of that, when the second outbreak came, the strength was leveraged on. The gaps, what was identified, the measures has been put in place. So that is how it has helped us in preparedness. So after action review is really very, let me come down to SLI project. SLI project was, when Tinuga was, we were designing the project, Dr. Tinuga was leading then in the central. He has an idea of devolution, decentralization of the activity. And Tanzania was the only place we had what we call pre-implementation campaign in different regions, where we allowed every region to determine how they want to operate. So some of the regions, I'm happy he's here. He was the RMO in Mara, and based on, he didn't use our model, he used his model, and he was able to do 1 million vaccinations in 1 week. It has never happened anywhere in Africa. And a round of applause for him. So what happened? How did it help our preparedness? We came for a year 2 implementation. We said, okay, what went well? After review, we found out that devolution and decentralization work. Can we still use the activity? We came back, we did the same. And this year 2, by the time we came, we had where we want to operate. We wanted to do Njombe, and only in Njombe here and Zanzibar. We still have to go back. Do you think it's okay? They say, no, this is what we want. We want to include Rindi. So I'm saying we learned a lesson that decentralization is okay and we have to use it. And it's working for us. The third part of it, during our SLA rollout, we found that there's a big gap on logistics of vaccination. And I'm continuing, but the leadership of Tinuga, African CDC has been training 497 vaccination around the country. It's actually ending today. And we learned a lesson, and we're trying to build the capacity. On the second part is on partnership and impact. African CDC is actually built on partnership. Partnership with the member states. When you say member states, we mean countries. Even our SLR project, if you can look at how it's designed in a collaborative way. Why partnership? We identify partnership to be key because we know that people have separate expertise. Amref, WFP, for instance, has separate expertise. Red Cross has separate expertise. So when you come together and we're in a round table, we can be able to say, what is capacity do you have? How can we respond? What resources do you have? And it has really been a key, and a key to the impact of our activity. I'll still go back to the Marburg outbreak. When the response team was activated, Amref was doing a separate thing. WFP was doing a separate thing. UNICEF was doing a separate thing. Red Cross was doing a separate thing. And they were able to achieve in a short time. And the outbreak was contained. Well, imagine if it was someone who did not have, Amref might still be able to do communication, but they might not have that kind of capacity with Red Cross and Amref and the tentacles. They might not have local volunteers that Red Cross have in every region. So we work together to achieve. And I mean, working together always gives an impact. So I will stop here and take other questions later. Thank you.
Thank you so much, Dr. Robinson. That was very good. And you can see exactly harnessing data utilization. And people were able to use data to progress and access. So thank you so much. And now we have the honor of having I start with Dr. Juma. I'll start with Sarah. I want to start with you. Juma will be speaking. Sarah, you've heard from Dr. Nanji, the successes, the capacity, building capacity and using data. So in the SLL project, how has the decentralization, which has been talking about, helped to improve the specific groups in the community where we're working, looking into women, children, and what was the lesson? Because SLL was really transforming immunization response across the community. We know that was the time. Now we have introduction of HPV vaccine, introduction of all these, under 5 vaccines, integrating it with the COVID-19 vaccine. And so there were very, very important lessons Sarah will share with us. Sarah Karim.
Good morning, everyone, and good morning, Dr. Isa. So I'll start with a story. Not long ago, in the rural outskirts of Zanzibar, I met a young, bright woman named Amina, who had never received an HPV vaccine. This wasn't because her parents were hesitant. This was simply because the nearest clinic was only 2 hours long from where she was. So that changed when a mobile clinic planned by the local health team that came directly to her school. Amina got her HPV, but not only that, something powerful happened. She encouraged her classmates to do the same. In her words, if the clinic came directly to us, then they really do care about us. So what's the moral of Amina's story? This means that when services come closer to you, then people come forward for the services. So this is what decentralization does. It removes barriers, and builds trust. So back to the question. So how does decentralization improve access? So through the Saving Lives and Livelihood project, we used the decentralized approach across all the regions that we implemented, including Zanzibar. So this was to ensure local decision-making and improve access for hard-to-reach groups, like adolescents and young women. So the other thing, by giving the regional teams and local teams authority to plan and implement strategies, we made the services more available to everyone, visible and accessible to everyone, especially to communities which previously had limited access of these services. So for example, in the regions that we were doing or working in, we guided the teams on how to develop microplans, whereby they had a component of outreach services. Through this, we're able to reach almost over 1,000 adolescents, and this has been a success, and this was done through school-based outreaches. Empowerment and ownership. Decentralization also meant local ownership by the regions, whereby the regions were given flexibility to be able to develop microplans and also different payment approaches that they saw would be good for them. Some opted for extra duty allowance, while others opted for pay for performance. So this actually were based on the region's option, and it ensured that the healthcare providers had accountability. So through this, we saw a very good performance and accountability of the healthcare providers. So we move on to data and impact on women. So we used the local data to prioritize mainly on the unvaccinated. So this led to more strategic outreach services. So this was done through school-based outreaches. So through this, we were able to reach adolescents with integrated outreach and also reproductive health messaging. So I would like to move on to scalability and sustainability. So because the SLL project leveraged on existing government systems, like using trained healthcare workers, national level database for the data, and regional oversight. So both of these are scalable and sustainable for us. And we have seen success using this approach in the regions that we are implementing in. So I would like to move on to the lessons through the decentralization by devolution. So we saw that it has assisted with local planning, whereby we involved the local teams, the local government authority. There was also flexibility of the regional teams to be able to do based on the local content. And also the data that we had was based on what is available within the respective regions. So we're able to reach those who needed the services more. And lastly, there's issue of community trust, which drives the demand. So lastly, I would like to share a feedback on the Amina story. This is just among a thousand that we have. But when we decentralized, not just the funding, but also the trust, we give regions the power to reach every child, every woman, every community. And that's how we build stronger and more resilient health systems. Thank you.
Thank you so much. Thank you so much, Dr. Sarah. That was very, very insightful. And we are glad of the initiatives that we are able to really transform the guidances and policies into action. But the most important is, she said, is reaching the important groups, the most also eligible and at risk groups. So thank you so much. I would like now to jump into our last speaker, Dr. What is happening with my question? Dr. Juma, yeah, I'm looking for the question. Yes, I've seen it. Technology can be a challenge sometimes. Juma, our esteemed RMO of Njombe, would like you to share the community-driven success story with potential scaling. How has Njombe leveraged decentralization, and what strategy engaged communities to drive demand for vaccine? Now we really want to hear from the host mouse. How were you able to drive this and make sure community engagement, acceptance, and utilization of immunization services using the decentralized model?
Good morning to everyone. Hello, good morning to everyone. Yeah, I'm Dr. Juma, a regional medical officer for Njombe region. But before telling the audience how we leverage decentralization and in which strategies, I would like to declare that I'm among the few RMOs who participated in the SLL1 and then SLL2. Accidentally, today I'm sharing the experience from the field as a panelist. Thank you very much, Amref. Yeah, I'm supposed to tell the audience how we're leveraging the decentralization. In Njombe region, through decentralization and through local decisions making and effective micro-planning. We have empowered the team with authority to map up all areas with a low uptake of the vaccine. I mean the villages, I mean the WAS and the mtaa, etc. And then we came out to identify the community leaders and select the suitable communication channels. We came to realize making a general meeting in the village or the city could not be a better way. So we came to find out to have to make a special meeting with the community leaders to get out the insights and to find a way forward how we can do it. But also we enabled and tailored the efforts instead of using one-size-fits-all approach. One council might be having one approach different to the other council, but also we leverage the decentralization by resource mobilization and outreach. We empower the CHMTs, health management teams, CHWs to coordinate the outreach. Logistics, they came out with a very good number of their under 5 who are vaccinated through a good coordination and logistics. But also we allocate the vaccine, we arrange the services, when, where vaccination will be taking place, and we have arranged the mobile services, where exactly the mobile service will be conducted. But also engage we do engagement and accountability at the local levels. That we engage the local leaders involved in the generating the demand and providing the feedback to the community. Not only that, but also what Robinson have said, we do what I call MAT, stakeholders collaboration. We may find sometimes we have the IPs who are doing the same activities in the same areas, but doing it independently. So what we did, we framed them together and we tried to make sure that we work all together by partnership among the IPs, RHMTs, CHMTs, political leaders, regional leaders, community leaders. And this one was among the issues which actually came out of a good coverage of vaccination. I know we all suffer from the issue of data. Data. If you tell somebody to give you a data of vaccination from facility X today, probably if you ask the same person tomorrow, he or she might give you a different data. So which strategy did you use? We used data. We did a micro planning. We went through a data triangulation from the Mtuha books, DHIS2, VIMS. Let me tell you one thing. If you cross-check the data from Mtuha book number 5, for example, I think Tunuga knows that more better. You may find the under 5 children who are not vaccinated, but brought in the facility by the caretakers or the mother seeking for treatment. But if they are vaccinated, probably will not find this under 5 coming for treatment. But the same group of children, if you cross-check the data from book number 7, which register under 5 who are vaccinated, probably you see they are not in book 7. But again, if you cross-check to book number 6, which register women who are pregnant mothers visiting the ANC clinic, probably these mothers' names are the ones who are registered in book 7 also, with their newborns. Probably
probably you will not find the names of the mothers from book 6 who were registered in book 7. This tells us that data, something which we need to handle it very clearly. And what we did, we tried to find the under 5 children who appeared in Mtua Book 5, which register OPD patients, and we came to find that a lot of under 5 children who appeared in Book 5 were not in Book 7 and were not vaccinated. So we tried to frame a special form, which we registered under 5 children from Book 5, and then we took it with healthcare workers and CHWs to the street, to the household, to find unvaccinated children, under-vaccinated children, 0 dose children. We actually came out with a lot of under 5 children who were not vaccinated. But again, we trained the healthcare workers in communication and vaccine services delivery at their localities. We did what we call cross-laning. We had a cross-laning from Jombe all the way to Kilimanjaro. I didn't say the RMO from Kilimanjaro here, but we found a lot of good things being done there in Kilimanjaro. In Kilimanjaro, what they can tell you from the RHMT level, it is the one which you are going to find in the dispensary level. Can you give a clap to Kilimanjaro? But again, if they tell you something from the RHMT level, clearly you find it very clearly at the facility level. But we learned a lot how to minimize access barrier and maximize the accessibility of vaccine from Kilimanjaro. And we came back to our region, and what we did, we tried to minimize the access barrier and maximize the vaccination by increasing the access of vaccine. What we did actually, we tried to shift. Instead of vaccinating the children within the facility, we shifted to the bus stop, we shifted to the marketplace, we shifted to prayers places, we shifted to daycare centers. My friend, we came out with a lot of under 5 who were not vaccinated. But also, we developed a micro plan with the CHWs to understand the access related barriers. You might not know, but keep in mind that we have a Git army. You might not know that, but the CHW is a Git army which bridge the gap between we, the healthcare workers, and the community. So, lastly, we use their trusted community members to increase the vaccine uptake, the CHW and the local influential leaders. But lastly, not the least, in the region we have a plan. We normally register the student at the time of the opening of the school. Why you register the students? We do that because we want to get exactly the number of the student who are supposed to get the HPV vaccine, whatever the TD, to know their birth dates. I once asked somebody in a certain meeting that, what if I ask you in this room, who is ready to be vaccinated now if I came here with a syringe? And no one who raised up the hand. Are you ready? Imagine you are in Njombe and it's a very cold place, and I come with a vaccine carrier with a syringe, and I'm telling the audience here that I want to vaccinate you for HPV. Who will be ready? No one. Few. So why we register the student in the beginning of the open the school, we want to get the exact number and want to get the appointment, of course. At the time of vaccinating, at the date of vaccinating, we are going to vaccinate exactly the number which you get from the date of registration. That is one of the strategies which it leads us to surpass the target of HPV target. Thank you very much, Asante.
Thank you so much, Dr. Mfanga. Very powerful testimonial, and I'm sure people have learnt a lot on we've seen in real time how decentralization by devolution actually means. If they don't come to you, you reach them. Issues of micro-planning, issues of openness, coordination of implementing partners, and making sure they maximize and leverage the resources that comes to your region. Thank you so much. I promised you I want this conversation not only to dwell on this platform here. I want each one of you to be part of this. So we have spared enough time for people to ask questions so that they can respond, to discuss, to share your views, etc. So I really want to thank each one of you speakers. You have shared very inspiring information and experience, and I believe now the audience is now ready to start this powerful conversation. Let's start the conversation. So we'll have the mics, I think, Priska. And then if people can raise your hand, rotate around. Is anything you want to share, to ask, you need clarification, we'll be happy to. So I start to see the hands streaming. Just a gentleman with glasses there. Do you see him? Yule pale. Simama tu akuone. We'll take 3,
okay,
and then we'll go another round. Yeah. So
my name is Rashid from Ministry of Health Zanzibar. First of all, I recognize.
Is the mic working?
Yeah. Yes.
Eh?
First of all, I recognize. The adoption of technology and innovation are critical for enhancing the effectiveness of the health system. And Mr. Florian earlier Mr. Florian earlier mentioned the challenges facing during pandemic. I want to know what are the challenges facing during the integrating of life cause immunization in terms of governance, financing, and community engagement.
Thank you very much. Yes, Daktari.
Good morning. My name is Kijakazi Mashoto, Research Scientist at the National Institute for Medical Research. I would like to join Dr. Mfanga to celebrate the health facilities in Kilimanjaro for having a high quality data. But my question is, do you know what factors contributed to the success in collecting higher quality data? It might be a good forum for other facilities to understand why did they perform exceptionally well. Thank you.
Thank you so much, Dr. Mashoto. Is there any other hand? Yes, you can stand up. Yes, there's a guy there, gentleman over there.
Okay, thank you. My name is Sahani Baraka from the University of Dodoma. I have two questions. The first question is, how do we use the youth force in implementing the program of immunization in our country? The second question is, how can artificial intelligence be applied in immunization program, improve vaccine coverage, monitor adverse events, and ensure timely delivery of vaccine in underdeserved communities? Thank you.
Thank you very much. I think we can start responding to this, and while others are still contemplating.
Thank you so much. Yes, there was a number of challenges with regard to integrating the life course vaccines into the routine immunization. And at times, what I spoke here we mean COVID-19 vaccine. In our country, we have two life course vaccines, which are HPV and COVID-19 vaccine. Some challenges which faced this kind of integration was, one, hesitance, and then the hesitance initially started from COVID-19, but later on went into the routine vaccines. Yeah, so we suffered the double effect. And then this is what I said, in the end, it made parents hesitating bringing their kids to receive the routine vaccines. But as we went on, we had to, because once you integrate at the first time, because it's a new phenomena, everyone hesitates. Now, but in the due course, we continue educating, giving capacities to staffs. I remember the staffs were the first group to propagate the hesitance, and then when we give capacities to our staffs, and then that could went off. But the other thing of integrating, it brings a burden to the healthcare workers in terms of service provisions. Yeah, initially it does. And it does so because once you integrate, the essence of integrating is to save resource, but itself, the resource has to be regulated. So in the first beginning, the resource regulation is not easy, but then in the due course, we found we regulated resources and we managed. So as we speak, integrating the life course vaccines into routine immunization has more positive effects than disadvantages in all aspects of service delivery, vaccine management, storage, transportations, but also data management. And currently we have advanced. We are now integrating the TIMLI is the electronic immunization system, which deals with routine data management, integrated into the GOT HOMIS, because the GOT HOMIS is the primary healthcare system, electronic healthcare systems, which manage data. So once we have done that, then we think we will do at the higher level of achieving in terms of integration. So I have answered your question. Initially, when you start integrating the life course vaccines into the routine, you get more resistance, but you need now to use different plans to achieve, to overcome the resistance. But in the end, you achieve. The question of artificial intelligence, I would beg we leave this discussion until other forum. Thank you.
Thank you, Mashot, of You want to know the factors favoring Kilimanjaro for their best performance. What I came to realize actually, Kilimanjaro have started decentralizing the issue of vaccine for a couple of years back. In the facilities, if you go to the facilities, at the dispensary level, they know how to plan for vaccination. They know exactly the target of the facility, and they know exactly the days when to do the outreach, when to do the mobile services. But also they are better in data triangulation. They normally do a weekly data quality assessment and monthly data quality assessment at the RHMT level. The weekly at the facility, but monthly at the RHMT level. And they do deal with what we call the scorecard for vaccine. They have the scorecard for vaccine in Kilimanjaro, but also they have a timely distribution of vaccine. Timely distribution of vaccine. I asked one of the healthcare workers when I visited Rombo District Council. Chanjo zinaisha. Sema zikiisha hapa ujue mkoani pia hazipo. You get me? Zikiisha hapa kituoni pia mkoani hazipo. And when I went to Pasua Health Center, I asked the same question, and the same answer I got. But they have a good thing. They have what we call a cascade supervision of most of us, we don't do that. A cascade supervision. They have trained the mentors. What they did, they chose among the healthcare workers who are good in vaccination, management, and then they tried to station them according to the geographical location of the council, according to the geographical location of the region. They told us, when we went to Same, where there is a lot of mountains, but iwe mvua, vaccination is there all the time. So the mentors, they have to make sure that the time for outage, the time for mobile services must be exactly in place. But also, what I found new in Kilimanjaro, if the PRAJ give us the target for the region, they just add 10%. If the council has to vaccinate maybe 40,000 under 5s, they add up 10%. I asked them why. They said, we are sitting here today, but somewhere in the facility, there's a newborn baby who was not in the target. So we are trying to make sure that we are not missing anybody. But also, they told me one thing. I'm not sure, and I'm not saying this because I'm coming from Kilimanjaro. They said the level of understanding of the people in Kilimanjaro is high. Thank you very much.
Okay. So, yeah, we've seen the power of cross-learning when we're designing this kind of initiatives. So thank you so much. We have 10 minutes left. We'll have 2 questions, and then they'll respond, and then we'll start closing because we want to complete here on time. Yes, there are hands over there. First guy on the front. I don't know.
Thank you very much. My name is Dr. Hassan Msafiri from Pangani. I would like to contribute on the PRG. Thank you for the integration of the teams into GoToMIS, which has helped us a lot. But when you're talking of the data on the immunization coverage, most of the people who help us to get the coverage are the CHWs. So what are the initiatives? So as the CHWs would know more better on the teams, so as if it is integrated into GoToMIS, it will help us as leaders to interpret the data and make sure the usage of data is enough.
My name is Lord Samuel Gunda. I'm CHW from Dar es Salaam. Please allow me to use Kiswahili in order to make a clear understanding with my explanation.
Please do.
Okay, thank you. Sisi watu wa huduma wa afya ngazi ya jamii ni daraja halisi kabisa la kuweza kuifikia jamii. Mimi nilikuwa naomba kutoa ka story kidogo ambacho kanatukwamisha huko kwenye jamii. Tunapanga mipango mizuri sana. Shida iliyopo ni kule chini. Cha kwanza ni kundi la kwanza la viongozi wa dini. Hatujawafikia tukawapa elimu sahihi kuhusu umuhimu wa chanjo. Hawa watu wanapokutana na watu, kuna baadhi ya vifungu vya Biblia vinakinzana na hizi huduma. Hasasa upande wa Wasabato, mtanisamehe. Tunasaidiana. Lakini mtazamo hasi kwenye chanjo ya HPV, hii pia inaanza kutoka kwa maafisa elimu na wakuu wa shule. Tukienda hatupati ushirikiano kabisa. Na wakati mwingine mwalimu anashirikiana na wazazi kuficha idadi ya watoto ambao wanatakiwa kupata chanjo, ambao kwa sasa najua ni wale wa miaka 9. Sasa kama wanawaficha, tutawafikia wapi? Tutawezaje kuikinga jamii na kama tunawalupu wengine? Lakini sababu zingine nafikiri ni wazazi nao wako bize. Sisi tunapokuwa tunakwenda kule majumbani kutafuta watoto ambao hawana chanjo, yule aliyeachwa hana idhini ya kukuruhusu wewe CHW uweze kumpatia mtoto chanjo pamoja na nesi wako. Na ukifanya hivyo, bado hatuna sera ya kulazimisha wewe kufanya huduma ya kiafya kinguvu. Nafikiri ni baadhi ya hizo changamoto chache tulizokuwa nazo. Tulikuwa tunawaomba nyinyi mnao tutumia kuweza kufikisha, tujaribu kutengeneza mawasiliano mazuri au andiko zuri ambalo linatoka juu kwenda kwenye hizo channel nilizozitaja. Lakini kingine cha mwisho kabisa, daktari amesema kuhusu data. Kadi inaweza ikawa haijajazwa, lakini mama anakuambia mtoto wangu amechanja. Sasa hapo na mimi nakuwa nashindwa kujua mtoto alichanja au hakuchanja. Asanteni kwa kunisikiliza.
Asante sana. Naomba nipeleke mic ili uweze kujibiwa vizuri.
Naomba tu nichangie. Nachangia kwanza hapa. Dr. Juma atalizungumza vizuri, lakini nataka nimpongeze kaka wa CHW, jina lake sijalipata vizuri. Nakumbuka, na hii nairudisha kwa ndugu zetu wa Amref. Nakumbuka vijana wa Zanzibar walikuja huku mkoani, mikoa mingi tu ya bara kuja kusoma, lakini eneo moja ambalo tumefanikiwa sana ni hizi changamoto alizozitaja kaka pale, na nakubaliana naye sana, na mtakubaliana na mimi kwamba sisi kule wa visiwani hizo changamoto ni kubwa zaidi, amplified 1000 times kuliko huku bara, kwa sababu sisi ndo tuna viongozi wa dini kule ambao wako highly charged, tuna wanasiasa pia ambao, na sasa hivi ni kipindi kigumu zaidi. Kwa hiyo ningeomba muwalete wenzetu wa Dar es Salaam waje Zanzibar hata siku 2 waje wasome. Asante sana.
Asante. Samuel Gunda, nashukuru, lakini nilikuwa naomba niseme kitu. Sasa sina hakika kama kuna wazazi wako busy kama wazazi wa Njombe. I'm not sure. Dar es Salaam sijui kama wako busy kama Njombe, kwa sababu Njombe watu wanaamka saa 9 za usiku, saa 10. Kwa hiyo kama anakichanga anakiweka kwenye ndoo, hata kama ni mtoto njiti anaenda naye shamba, and then anamtenga chini ya mti, anafanya kazi zake. Akilima viazi akimaliza yuko busy, anaenda naye sokoni, anamweka chini ya meza, anauza viazi vyake. Akipata pesa anampelekea baba. Sasa samani kama kwa mtu wa Njombe yuko hapa, lakini what I want to tell you, nachoweza kukuambia, na hiyo ndio sababu kubwa inasababisha Njombe tunakuwa na udumavu, kwamba all the time we don't have the caretakers. Inawezekana moderator caretaker wake anatoka Njombe, maana ni wafanyaji kazi wazuri, lakini nataka nikuambie what need is we have to play with mapigo ya ngoma yanavyoenda. Kama wao wanataka kwenda shamba, watafutie wende shamba. We have a very big tea farms in Njombe. Tunaenda huko mnachanja pale, tunamalizana nao. Sometimes ukienda Njombe DC, wao wazazi wamejiorganize, wametengeneza day care center ya kwao, kwamba sisi tutawacha pale tunaenda shamba. Sasa unabidi uende pale. Njombe wana cycle ya shambani, sokoni, kanisani au msikitini. Hizo sehemu 3. Sasa wewe unachagua wapi utakutana nao. Sasa ni vizuri sana, that's why kwa decentralization tunazungumzia wao wanatakaje, alafu sisi tutafanyaje kwa utaalamu wetu. Wao wanatakaje? Wanataka twende kanisani. It's okay. Tutakuja na chanjo kanisani, baada ya ibada tutachanja. Mnataka sokoni? Yes, tutakuja sokoni, tutafuta eneo tutachanja. Kwa hiyo tusiache kuchanja watoto kwa sababu hiyo. Secondly, nilizungumzia registration ya watoto kwenye shule za msingi na sekondari, hasa wale wanaopata HPV na zile TD. Sasa the issue is, tukienda kuregister pale, moja ya kitu ambacho mimi naamini, tuna mahusiano mabaya watu wa afya na walimu. Na what they believe ni kwamba sisi kwenda pale we get a lot of money through kuchanja. Kweli si kweli? Yes, tunapata hela nyingi sana. Chanjo outreach ni kazi ya mtumishi wa afya anayeenda kutekeleza majukumu yake kawaida. Haimaanishi kwamba kija pale ni program ambayo inalipa pesa nyingi, hapana. Sasa tulichofanya ni kwamba kwanza tunakuwa na mahusiano nao. Kwa mfano we have other projects in Njombe ambazo walimu wanahusika. Kwa mfano we have a forum for nutrition. Kwa hiyo kukiwa na issue tunawaita walimu, wanakuja. Kwa hiyo they think we are together, lakini sisi tukitaka tuwavute ili tufanye nao kazi kwa karibu. Kwa hiyo ukienda shuleni kuregister, inabidi ukae nao vizuri, uongee nao na nini, usikilize. Ukikutana na mwalimu siku amekuja yuko OPD, unaambia mwalimu njoo. Unakuja na wanafunzi, unaenda anatibiwa mara moja na anarudi. Sasa ukiacha ukaona wao tu ni walimu, na wao wanatudharau kwa sababu wametufundisha, alafu sasa hivi tuko juu yao. Sasa hiyo tatizo linaanzia hapo. Kwa hiyo ni lazima uongee nao vizuri, na lazima uhakikisha unakuwa na appointment na yule mwalimu anayehusika na mambo ya afya. Sisi tuna platform ya walimu wa afya ya mkoa mzima wanaodili na mambo ya lishe. Kwa hiyo ukiongea nao tu vizuri, hii habari ya mtazamo hasi inapotea. Nataka nikuambie, last year tulivaccinate wanafunzi wengi sana. Tupata 96 vaccination ya HPV. Mwanafunzi mmoja alipata was like a hyperzoster something. Lakini yule mwanafunzi babake akasema ni kwa sababu ile chanjo. Nataka nikwambie mwanafunzi alifariki, lakini alikuwa na ugonjwa mwingine sasa kuutaja hapa. Lakini babake humbadilishi. Na alienda shuleni akamwambia walimu, hiyo chanjo inaua. So you need to be very careful. Na utafute forum ya kuongea na mzazi wa namna hiyo. Lakini kadi haijajazwa, la mama anasema mtoto amechanjwa. Let me tell you, kadi imejazwa lakini mtoto hajachanjwa pia. Kuna wale wa mama ambao ukichukua syringe ukainyosha hivi unapeka kwenye bega, anafanya sijui kama mshakutana nao. Yaani mama mwenyewe anaumwa, anachoma mtoto lakini mama anaumwa. Sasa hawa ndio wengi wanawakatalia kwamba mimi mtoto wangu sitaki achomwe. Sijui kama inaeleweka. Sasa unachotakiwa kufanya, Samuel, inabidi uende kwenye kitabu namba 7 ukasome jina la yule mtoto, afu uangalie yule mtoto trend yake. Huyu mtoto mama kaniambia amechanjwa. Tukichanja tunaenda huku. Tunaangalia kwa sababu kwenye tally sheet utakuta huwezi kukuta jina lake. Lakini ukienda kwenye kitabu namba 7 ukiangalia utakuta huyu mtoto amechanjwa hajachanjwa. Lakini mtoto pia anaweza kawa kadi imetikiwa kote. Ana miezi 5 afu kashamaliza chanjo zote. So need be very careful. Inabidi uende upitie kitabu namba 7 uangalie. Asante.
Thank you so much. Yeah.
So the final now.
Right
the CHW training on integrated goat home stimuli will not be excluded. Currently, we are not at the final stage of the process. We are in the middle stage. So once we have done, during the rollout, all these will be considered. Thank you.
Thank you. Thank you so much. Powerful experience and information from our esteemed guests. Naomba mwapigie makofi. Tumeiba muda wanaofuata, lakini we have had a lot issues of collaboration, partnership, coordination, accountability, sharing lessons, co-designing, transparency, collaboration with ministries, implementing partners, etc., capacity building, and we've heard about impactful framework and the resource mobilization strategies. So with this regard, I want to thank each one of you for joining us today. Niwatakie kila laheri na asanteni sana. We are closing our forum. Tunabaki kupiga picha, si ndio? Yeah. Thank you.
Sorry, on behalf of Tanzania Health Summit, I would welcome Dr. Samuel Mara, chairperson of District Medical Officer, to present a trophy and certificates to Dr. Isa. Trophy and certificates of appreciation. Can stay at the middle, please. Trophy and certificates of appreciations for their significant roles in the success of the 12th Tanzania Health Summit. Thank you so much. The next sessions after this is a District Medical Officer Forum session. Please, Terry, where you are. Welcome.